Thank you, Dr. Danforth. Thank you, Dr. Mann. Doug Mann's doing a great job in leading the cardiovascular division at Washington University, and you're all proud of him, I know, and you'll be increasingly proud of him in time. I didn't bring any slides. I wanted to talk to you from my heart about stem cells and heart disease for just a few minutes. So just a few things. Heart disease, heart and vascular disease are the #1 killer in every country in the world of men, women, and children, all three. If you're a woman in the United States tonight, there are 41 million women living with heart and vascular disease. There are 5 million women living with cancer. There's an 8-fold difference. Most women don't know this. If you're a woman, you're 5 times more likely to die of heart and vascular disease than you are of breast cancer. And if you're a woman, you're more likely to die of heart and vascular disease than you are of all cancers combined. For the men, 1 out of 2.5 of us worldwide will have heart and vascular disease. And there are 25,000 children born in the United States each year with congenital heart disease. In the United States, every 3 or 4 weeks, a young person drops dead on the playing grounds or playing fields after hitting the winning home run, scoring the winning touchdown, and so on. There are 4 causes of that sudden death in children. They're all cardiac. So the real threat to every one of us walking this planet is heart and vascular disease, and can strike suddenly. You have friends who've been well, no symptoms, or well 5 minutes before they drop dead. And what happens is they rupture a plaque in a coronary artery. It ulcerates, and a blood clot forms there and obstructs the heart of blood. And it's often a major artery, and they die immediately. No second chance. So heart and vascular disease are real important. So are stem cells. We're all walking stem cell products. Do you realize that? For one who says they're not interested in stem cells or they don't believe in stem cells, they don't understand their own biology. The union of 2 cells, our father's sperm and our mother's egg, created billions of stem cells in a sac called a blastocyst. Those cells were ordained by our Maker to be your heart, your brain, your kidney, your liver, your appearance, your soul, your intellect, your spirit, everything about you. Everybody know that? Realize that? So how could we begin to talk about not wanting to use stem cells to repair things? They're our own. We are stem cells. 2 other things. Our Maker gave us a circulating rescue system. Stem cells coming out of the bone marrow, patrolling the circulation. They're largely CD34 positive cells, and they're looking for areas of injury, like a heart attack or a stroke, to repair. They're also resident stem cells in every organ of the body. We have them in our brain, our heart, our kidney, our liver. They're meant to be activated and repair. Beautiful system, huh? Elegant system of rescue. And you know what? It does not work very well. This is a real enigma. Why we would be created with systems like that, be products of stem cells, and when we have a heart attack or stroke, with rare exceptions, these cells don't help us very much. Why not? Well, those from the circulation come too late. You've got about 2 hours with the heart, with an evolving heart attack, to arrive and repair if you're there in significant numbers. There are too few resident stem cells to make a difference. But there's another problem. When we're 60 years of age, thereabouts, give or take a little, our stem cells are dysfunctional. They're sick. They cannot reproduce themselves in culture. And that's what a stem cell does. That's what a stem cell is. It's a cell that can become a cell of any organ in which it's placed, and it reproduces itself. But as we age, they cannot. We found this. It's been confirmed by others. So that's really a cruel joke, don't you think? This elegant system, beautiful system, meant to rescue us, and when we most need them, they are dysfunctional. Well, there's an opportunity here. It's one we're exploring. Why are they dysfunctional? What could be done to resuscitate them? I think they can be resuscitated, by the way. Doug, if you invite me back a couple of years, I hope I'll be able to tell you we've done it. But what about stem cells that do work? A colleague of mine, Dr. Emerson Perrin, a native Brazilian student of mine at the Texas Heart Institute, and now a partner and brother, really, and I formed a clinical research relationship with the Hospital Pro Cardico in Rio de Janeiro, Brazil, in 1996. I thought we would begin some gene therapy for the heart, but we were also working on stem cells in animal models, rats and rabbits and mice, creating heart attacks and determining what stem cells could do. And by year 2000, we were convinced that stem cells could be given safely and would be reparative of an injured heart. Because we had this research relationship in Brazil, and also because I didn't think the FDA would approve this effort here, we asked the Brazilian authorities in this hospital to let us treat humans with severe heart failure with their own adult stem cells taken from their bone marrow and injected into their heart. We had a special catheter that we'd worked with. It's called a NOGA, N-O-G-A catheter. And it's a catheter that's put into an artery in the leg and threaded backward into the aorta, across the aortic valve, into the cavity of the left heart. Where that cavity touches heart tissue, it measures the electrical potential and also provides an analysis of the velocity of wall motion. It has a needle on the end of it. You can protrude and withdraw. You can see what we were trying to do. We wanted to inject the patient's own human adult stem cells taken from their bone marrow by an aspiration procedure into sites that were not dead and not normal in the human heart. Heart and vascular disease is the number one killer of men, women, and children throughout the world. Heart failure is the number one cardiovascular problem. You're fortunate to have Dr. Mann and his colleagues here working on that and making great progress. Heart failure occurs when the heart's injured, typically, usually by a heart attack, but it can be a virus or excessive alcohol or certain medications like adriamycin used to treat breast cancers in women, or genetic predisposition, or getting older. And when the heart's injured, that segment of the heart does not contract normally. So your heart is fist-sized. If you put your fist over your left chest, you can estimate, you can see the size of your heart, and they all vary depending on our size. It contracts vigorously and relaxes vigorously. But when it's injured, that part of the heart doesn't move normally. So it starts to look like this. And when that happens, the heart enlarges progressively. And ultimately, in its end stage, becomes basketball-sized, fills the whole left chest, and just quivers at the top. That's end-stage heart failure. Heart failure, the most common cardiovascular disease among this killer. And when one has that problem, one can't walk from here to the wall because one has neither the energy nor the breath. One cannot sleep with one's head down flat. You can't breathe. If you sleep at all, you're going to sleep sitting up or maybe standing up. And 3/4 of these patients are dead in 3 years. It's as bad as any cancer. This is a kind of heart failure that gets a heart transplant, but there are problems with heart transplants. 5-year survivals are good, 10-year survivals are not so good. And there are not enough donors to even make a big dent in the heart failure problem worldwide. We use left ventricular assist devices. We've been involved in that at the Texas Heart Institute for 40 years and have placed more than any other entity. These are small pumps that assist the failing left heart, typically by taking fluid out of the left heart and then pumping it back into the aorta, so taking the load off the heart. Recently, we've created a total artificial heart with 2 of these pumps and had a patient do very well with it. I think it'll be the new artificial heart. A woman, 21-year-old woman with one of these, is married. She's referred to as a bionic bride in Houston. And they're successful, but this is an operation. And it's a mechanical thing. So we wanted to do this naturally. We wanted to repair the heart with one's own stem cells. After about 8 months of questions in year 2000, early 2001, we were allowed to begin. And we treated 4 patients for safety, taking from their hip a bone marrow aspirate, separating out the cells that would likely be stem cells, marking them with all known markers, which was not entirely adequate. There were ones we couldn't identify. And then injecting into the heart at 15 different sites, inner wall of the heart with this catheter, 2 million putative stem cells, 15 sites, 30 million putative stem cells. The patients, the first 4, went home the next day. There are no new drugs here. These are their own cells. No reason to add an immunosuppressive drug, as you have to do with heart transplants. We were allowed to treat 14. This was the first such study in the world of its kind. It was safe, no harm to anybody. They all went home the next day. And then 7 clinically matched patients. As the first such study, this was not randomized and blinded and placebo-controlled. But within 2 months, the patients had better blood flow to their hearts, those that were treated. And within 4 months, they had a doubling of the velocity of wall motion contraction at the sites that we injected, and an increase in the global function of the heart. This is published in Circulation in 2003. Doug referred to that a minute ago. So, preeminent heart journal of the American Heart Association. I was the editor at the time, as he mentioned, and just as an aside, after we had submitted our paper to Circulation with a guest editor, 2 weeks later I received a paper from Germany from a man named Bodo Strauer. We didn't think there was anybody else in the world doing anything like this, but Strauer was in Germany. He was treating patients with acute heart attacks. We were treating patients with end-stage heart failure, with multiple previous heart attacks, who'd already had bypass procedures and stents, and for whom there was no other treatment in Brazil. But he was treating patients with acute heart attacks, which are caused by a blood clot in an artery, as I mentioned a minute ago. And he was opening the artery with a balloon, a stent, and injecting the patient's bone marrow-derived stem cells into that now open artery. And he showed what we had shown, that there was an improvement in function of the heart. 2 weeks later, another paper from another German, this man, Andreas Zeyer in Frankfurt, Germany, doing exactly what Strauer had done, showing exactly the same thing. Doug, I reviewed their papers myself in 1 week, and we accepted them. Our guest reviewer put us through 2 or 3 reviews. This tested my fairness as an editor to its limit. But those are the first 3 studies, and ours the first in people with heart failure and coronary heart disease. In 2004, we went to the FDA in this country. I thought maybe now. There were 60 people in the room. They seemed a little embarrassed to me. They knew what we had done in Brazil. And they began to ask a lot of questions. And after about an hour, I was sort of worried about what the result of this was going to be. And finally, I stopped them and said, listen, I'm an American. I'm a Texan. We want to do this work in Houston, Texas, at the Texas Heart Institute, and then have it spread throughout our country. But if you don't let us do it here, you're going to watch it done all over the world, because we are going to do it. Questions got softer. And after a little while, they let us proceed. So we reported in the last year the second such trial, same patients, end-stage heart failure. No other option unless it would be a heart transplant in our country, and we can do that, or an LVAD. But we're trying to do it naturally. we were given permission to do a 30-patient trial, 20 patients treated with the cells, 10 controls. Basically, we confirmed what we found in Brazil, but with one caveat. We saved an aliquot of the material that we injected into each heart this time. We wanted to look at the functional capability of the stem cells in culture. Could they reproduce themselves? Could they migrate? Those kinds of things. Have to do that if they're healthy. And that's where we found that around the age of 60, unfortunately, for many of us and others, stem cells are dysfunctional. And when you put the dysfunctional cells into the human heart, nothing happens. It's a nice control, but sobering. And the cells that can reproduce themselves and migrate improve the function of the heart and the blood flow to the heart. We've just completed a third such study, now 92 patients. 5 clinical centers involved, NIH supported. Our study in Houston was randomized and blinded, and so was this study that we've just reported. And again, we found essentially the same thing. Generally, the contraction of the heart is characterized as a so-called ejection fraction, and it's normal above 55, maybe 50. Patients we treated had very reduced ejection fractions, and we injected into their hearts again in the 5 different centers. But those who had relatively normal stem cells from their bone marrow got an increase in ejection fraction with the cell treatment. And the more normal the stem cells, in greater numbers and the more normal functioning, the greater the increase in ejection fraction. We measure one other thing too, and that's maximal oxygen consumption by the heart. And in the younger people with normally functioning stem cells, in this last trial, there was an increase in myocardial oxygen consumption. Now, I know today that the bone marrow-derived stem cells will not be the best. They're helpful, and they do the things I've mentioned, but they're better adult human stem cells. So as we've been studying the cells from the bone marrow, we've also been studying individually all of the known human adult stem cells. They're in the bone marrow, but our maker also placed a very potent stem cell in adipose tissue that any of us have. It's a mesenchymal cell or pre-mesenchymal cell. It's present in the bone marrow too. These cells are capable of making a lot of things, including bone. But they also cause new blood vessel development and improve blood flow and function in our animal studies and now in human studies. So again, with Dr. Perrin and a multi-center trial, we took mesenchymal cells from an 18-year-old donor from his bone marrow and used those cells, expanded them to treat 62 patients with both ischemic cardiomyopathies, that is, the patient had coronary disease, multiple heart attacks, stents, CABG, and so on, and patients with so-called non-ischemic cardiomyopathies, heart muscle disease that leads to the same enlargement of the heart and the failure of the heart, but it's not coronary disease, probably most often a virus, but it could be other things. In those 62 patients, both conditions were represented. And we reported this last November at the American Heart Meetings. What we found is that injected into the heart in the way that I've described, patients had better, the treated patients, both ischemic and non-ischemic cardiomyopathies, had better blood flow to their heart, better function of their heart, and in the ischemic cardiomyopathies, there was no clinical event in the treated patients in the next year and a half, which is almost unheard of. There are other useful adult stem cells. They include a CD34 positive stem cell. It's the one that patrols the circulation looking for areas of injury. That cell's been useful in forming new blood vessels in the human heart and relieving angina, the chest discomfort that some people with coronary disease get that can be very serious, limit anything they can do, put them constantly at risk for a heart attack. And these cells have been useful in changing that. And there are others. I won't bore you with the names, but the point is clear. These adult stem cells, when they're functioning normally, can be an enormous help to a failing human heart or a heart with a heart attack. We've also been treating patients with peripheral vascular disease for some years with stem cells. These are patients with atherosclerosis in the arteries of their leg, reducing flow to their leg so that the person who has this problem can't walk very far without pain in their thigh or their calf. But as it progresses, it leads to ulcerations on their toes, gangrene of their toes, and amputation of their foot or leg. And we have found that the stem cells that overexpress aldehyde dehydrogenase, we call them bright cells, from the bone marrow, a rather primitive stem cell, markedly improve the blood flow to the legs of these patients. So do the mesenchymal cells. I've already alluded to it, but I want to say it directly. The mesenchymal cell and its precursor is not rejected when given from one human to another. It's the only cell in the body I know that to be true of. That's how we could take an 18-year-old's mesenchymal cells and use it in adults in the 62 patient study I referred to. About 5 or 7% of patients who receive these mesenchymal cells have a transient marker of immunologic reactivity that goes away. And 95% of these patients show no recognition of this being a foreign cell. So that's an enormous advantage too, and will be a cell type that we use. There are two other cell types of interest that I do want to name. One is called c-KIT, small c, small k-I-T. It's a resident stem cell in the heart that's activated with injury to the heart. And Dr. Piero Anversa, who in Italy originally and at the Brigham and Women's Hospital, Harvard, Boston now, has identified these cells. You have to biopsy the heart to obtain these cells, and then they can be grown up in culture. So he and his colleague, Roberto Bolli at the University of Louisville, in February, reported a series of patients who had undergone recent bypass surgery, CABG procedures, and 60 days later received these c-KIT cells injected into their heart in the same way that we do. And they interrupted their study early to analyze the results, which you don't generally do, but the results were very impressive. There was an improvement in the function of the heart and a reduction in events for the patients, just like these pre-mesenchymal cells we've studied. And you'll read about one other cell. It's called a cardiosphere. And it's not really one cell, it's a heterogeneous group of cells. Dr. Eduardo Marban at Hopkins earlier and now at Cedars-Sinai has identified these cells. They're called cardiospheres because when they're put into culture, they round up, they curl up into balls. But they actually represent many of the cell types I've just talked about. They're just resident in the heart. The CD34, the mesenchymal, the CD133, so on, cells. So he's treating people with this heterogeneous stem cell population. Nevertheless, in a recent study that he conducted in patients with recent heart attacks, opening the artery and injecting the cells, there was a significant improvement in the form of reduction in scar. Now this is a little controversial at the moment, but it's interesting. What the adult human stem cells do best in a heart is improve blood flow. But when they're functioning normally, that improvement in blood flow and some differentiation improves the function of the heart. The stem cells differentiate when normal, and they're also so-called paracrine factories. The stem cells have in their cell factors that promote blood vessel development, life of a cell, inhibit death of a cell, and so they have multiple advantages. One, they can differentiate into cells that one would want them to be, and two, they put into the local environment factors that are pro-health, pro-life. Now, there have been arguments in medicine in our country and throughout the world about whether the major effect is a paracrine effect or it's a differentiation effect. So some years ago, we took mice called SCID mice, it's SCID. They've been engineered so they cannot reject cells from another mouse or even from humans. They're immuno-incompetent. And we created a heart attack in these mice by putting a suture ligation around an artery on the front wall of the heart and injected our own circulating progenitor cells into the tail veins of these mice. So human CD34 positive cells into the tail veins of mice that cannot reject the human cell. Now, how could that help us? Well, the human and the mouse X chromosome are different, and they can be differentiated. And so we can follow the human cells as they enter the venous system of the mouse and move back toward the heart or wherever they go, and determine where do they go and what do they do when they go there. And the answer is they go to the area of the heart attack, and there they differentiate into smooth muscle cells, is important in the heart, new blood vessel cells, a few new heart muscle cells, but most of the human cells seek out and fuse their nucleus with reversibly injured myocytes in the mouse heart. They ignore the dead cells and they ignore the normal cells. Do you understand? Human cells seeking out the reversibly injured mouse cell, fusing its nucleus. Now, what in the world is the point of that? We thought it must be like tossing somebody a life vest or inner tube is drowning, and that turns out to be exactly what it is. When these cells fuse their nuclei, the cell cycle is turned on, and brand new cells are generated in their myocytes. Now here's a generation of stem cells without killing anything. I haven't mentioned killing anything. This is a maker of the mouse and the maker of man's system for rescue. We've identified the receptor by which that occurs, and we can promote it. If you put such cells into an environment where the oxygen tension is low and there are cytokines that have accumulated, interleukin 6 and TNF alpha, the phenomenon is markedly enhanced. One other thing. Dr. Robert Schwartz at our group at the Texas Heart Institute and our team has recently shown that we can take a biopsy from your hand, probably from any part of your body, as dermatologists do. Anybody had a skin biopsy? Look at a mole, remove a cancer. We can take those cells and put them into culture. And now within 2 weeks, by administering, with the help of a virus, 4 gene products to these cells in a culture dish, we can convert them into your contracting heart muscle cells in 2 weeks. Not destroying anything, not using anything but your own source of heart muscle cells. Has anybody confirmed that, Dr. Willerson? Yes. Dr. Eric Olson at UT Southwestern, partner of ours, was aware of that, and he, a little smarter than I am, he took the SCID mouse and with the heart attack that we've been using and injected 4 transcription factors that are critical in becoming a heart muscle cell directly into the heart of the mouse and converted the in situ fibroblasts, the skin cells or fibroblasts, but they're resident in the heart, and he converted them in the heart into functioning myocytes, just as we'd done in culture. And I read that somebody in the UK has also used the culture method to convert fibroblasts to heart muscle cells. That's the first step in regenerating the whole heart. Let's go back to that blastocyst for a moment. Our creation. If we understand the genes that are involved in in that sac cells becoming heart muscle cells. We do the same for brain cells and liver cells. Those cells will be reproduced too in culture. But for the heart, this should now be possible for every structure in the heart. Heart has heart valves, 4 of them, has a complex electrical system that activates the heart and causes it to contract. It has a fibrous skeleton. All of those should be possible to create with the same strategy. We've also just recruited a very fine cell biologist named Doris Taylor. She was at Southwestern while I was and known each other a long time. She's been at Minnesota most recently. But she's taken animal hearts and human hearts and developed a cocktail that she can perfuse the heart with and remove all of the cellular elements from the heart. So the heart contracting normally, red, vibrant. She infuses this cocktail and the heart stops. And all of the cells of the heart are removed. And so one's left with only the skeleton of the heart. It's not injured, but it's dead. She now puts his heart in a support chamber and restores it fully to life by injecting the same stem cells that we've been talking about. There's the structure of the heart to be regenerated. I can't tell you how important I think that work like this, which others are doing too, I just happen to be the spokesman tonight, but others are doing with the brain and other organs is, I'll predict for you that every organ of the body will be regenerated from stem cells. Will embryonic cells play a role? Probably. But it's amazing what the healthy adult cells can do. But in some of your lifetimes, probably not in mine, but although I think the heart will be regenerated in mine, I hope. We're trying. Every organ of the body will be regenerated. So if that's right, some people say to me, Dr. Willerson, will I have to learn to read again? Will I have to learn who my friends are? Will I have to learn how to behave? Do I have to go back through all the experiences of my adult life? I don't know. But I'm sure it'll happen. And I hope Missouri will really become very, very supportive of stem cell work. Great pleasure and honor to be here, an honor to be with you all. I'm a big admirer of what goes on in St. Louis in lots of areas, including the Cardinals, by the way. Not so much the Rams. But certainly in medicine. Certainly in medicine. And I'm really honored to be here. I'll answer any questions that you have or try. Okay, let us get you a microphone. We're going to bring you a microphone, okay? Let's give it to you, I hope.
I can say it loud enough, sir.
Hang on just a second. Everybody will hear you.
2 parts. One is, can you define mesenchymal? I don't know what that, can you put that in layman's terms?
I'm sorry?
Mesenchymal? I don't know.
Mesenchymal cells, yeah.
What are those?
They're a stem cell. They're a bone marrow derived and adipose tissue derived stem cell. They're a little larger than other stem cells. I wouldn't put them down a coronary artery. They could occlude some very small arteries. As you heard, we inject into the heart muscle. But they're cells that were placed by our maker to be reparative. They can make a whole bunch of things depending on the environment they're in. I mentioned they can make bone and cartilage. They can improve blood flow in organs, the heart. And probably many other things we don't know about yet. They're a little sticky. They stick to plates. They have certain characteristics that allow them to be identified beyond that.
And the follow-up to that is, in Texas, can you just tell us what your experience is with issues concerning stem cells?
Is my experience what?
The issues surrounding stem cells, like the whole reason we created...
Have there been problems in the legislature with doing stem cell research in Texas? And what steps have you and others in Texas taken to overcome them?
There
You
were
might learn
some.
from.
Yeah, it's a good question. Texas is generally supportive of the adult stem cell research, but it's recent. About 8 years ago, I wanted to introduce into the legislature a bill that would create a large amount of money, as has been done in California, for stem cell research. Lieutenant Governor was very supportive of that. It had passed both houses. And then the right to life people objected. There were certain political races coming up soon. And that bill never saw the light of day. It got put down and pulled back because there was a threatened veto at a higher level. 4 years ago, we were able to show the Lieutenant Governor what we're doing at the Texas Heart Institute. And I went back to him and I said, let's create this fund now for our stem cell research in Texas. He said, Jim, I'd love to, but Texas was having a hard time. It maybe not as hard as some other places, but we've had deficits of $5 to $15 to $20 billion going into the legislative session. And most state institutions have had their budgets reduced. So he said to me, what do you need? And I told him, at the Heart Institute. And he said, we'll try to get it. And he got some of it. We're going to try again, although in this biennium, it's still difficult in Texas. We're going to have a budgetary deficit of somewhere around between 10 and 20 billion again. Although oil's selling at a pretty high price, so maybe it won't be quite so bad. There are good things about everything. Generally supportive now, not of embryonic cell research, but of adult cell research. You could ask me, what kind of problems have you seen in following these people over time? After all, stem cells could become cancers. Medically, it's a teratocarcinoma. If they divided in an uncontrolled way, adult cells don't seem to, with one exception. I'm aware of one patient who developed a teratocarcinoma in a kidney after some stem cell work. Now, this is out of hundreds, maybe thousands of patients have been treated now. We've treated over 200 patients. They're adult stem cells. The embryonic cells, that'll be a real worry for uncontrolled growth. We'd like to be able to turn them on in their proliferation and turn them off. And there are ways to do that with gene activation. And we're incorporating that too. And developing ways to recruit the circulating stem cells to the heart and have them stay there in larger numbers. We can now label the stem cells that we inject and follow them with imaging procedures. And we've done that in mice for over a year. Yes, sir.
Could you find that a way to examine those stem cells to see if they had cancerous genes in them?
They don't lead to cancers. They really, we haven't examined them for cancerous genes, but they don't lead to cancers. And one can safely say with now some 7 or 8 years of follow-up, now you could say that's not long enough, Dr. Willerson. How about 20 years of follow-up or 30? We don't have that yet, but I don't think they will. Embryonic cells, I'm very worried about that. Yes, ma'am.
How long do you think it will be before you see more widespread human clinical trials? How long do you think it will be before you have more widespread federally approved clinical trials? I think you said you did, first was 14 people. Do you see more widespread trials coming up?
So she's asking when we think we'll see more clinical trials in stem cells.
Okay. There are a lot of trials with stem cells now. We're in a 7-center consortium supported by the NIH for the next 7 years. And we were just in a 5-center consortium supported by the NIH. There's work with strokes and brain trauma, kidney injuries, spinal cord injuries, and work all over the world. It's really moving very quickly.
In cardiology today, there are probably 20 clinical trials ongoing in stem cells, many in the center that Dr. Willerson mentioned, but there, at least in cardiology, there are probably 20 trials going on at this minute.
It's growing quickly. It's gone from 1 or 2 to a large number. And that's what happens when it's successful. Okay, thank you very much.
That was excellent.
Do I have to wear it tonight?
No. Do you have to wear it on the plane going home?
Thank you.
Dina? Yeah.
Thank you. Thank you.
I just want to thank everyone for coming out tonight. Thank Dr. Willerson, Dr. Mann, and Dr. Danforth. As you've heard, we still have a challenge here in Missouri. We still work hard to protect stem cell research. So programs such as this are so important. We have WashU researchers and physicians, University of Missouri researchers and physicians, Stowers, and we provide education programs all over the state. So I really appreciate you coming out tonight and joining us.
Thank you. I hope it does what you.
I mean, this is.